This podcast is intended for veterinary professionals. Whilst members of the public are welcome to listen, please note that the discussions are designed with a clinical audience in mind and may include technical or treatment-related content. If you are a pet owner with questions or concerns, we always recommend speaking directly with your own veterinary surgeon who knows your animal best. So hello and welcome to this episode of the Nupsala podcast. Today I'm joined by Simon Constable from Simon Constable Equine Vets up near Manchester in the north of England. Simon gained his RCVS Orthopaedic Surgery Certificate in Advanced Veterinary Practice in 2012 and then added his Advanced Practitioner Equine Soft Tissue Surgery certificates in 2023. Over the years, Simon has been a regular visitor to Hoys, both in a supporting role to his wife Emily, showing in the Arab classes, and then most recently he competed in the lead rein pony class with his daughter Zara, coming 6th in quite strong competition. So welcome, Simon. I'm really pleased to have you on the podcast. We've known each other quite a long time now, haven't we?
Yeah, hi Meg. Yeah, thanks for inviting me. I do appreciate it. And yeah, we have. It's many years, isn't it?
Yes, yeah. So we were just catching up, and I remember when your first daughter Zara was born. So yeah, we're going back a few years now. She's now competing at Hoys herself.
Yes,
brilliant.
She's doing very well. Yeah, yes, and Izzy as well. My youngest daughter. She's getting keener now. She's only 4, but she's getting a little bit more enthusiastic, shall we say?
Oh, great. I look forward to seeing their progress over the next few years. So we mentioned there your practice is in near Manchester in the north of England. Can you tell us a little bit about your practice and how you got started with it?
Yeah, we're a 100% equine practice in the northwest, cover this sort of region, quite a large area. I started out quite a number of years ago now, 1997, and it's built up over the years. We've more recently, I suppose, added sort of quite a large operating theatre. We do quite a lot of surgeries there, a lot of orthopaedics, arthroscopy, a lot of soft tissue surgery, various sort of things. We do elective surgeries rather than emergency surgeries. So any colics go to Liverpool University, Lea Hurst, which is quite close by. But we do a lot of all the other stuff.
Fantastic. And how many vets have you got there in the practice now?
6 of us altogether at the moment.
Yeah. And what about your kind of client demographic and the horses that you look after?
Yeah, it's very wide ranging actually, from everything from show jumpers, dressage horses, eventers, hunters, right through to pleasure horses, show ponies, obviously a lot of those. There's quite a lot in the northwest. Show horses, show ponies are a big part of our work, definitely, and quite demanding as well. And I know it's regarded as a sort of a beauty parade, but it does require them to be completely sound. They can't have any sort of minor lameness visible. Otherwise, obviously that will prejudice their ability to win a class.
Yeah, and I can see that your experience of showing would be a really great asset to those customers as well. That you know exactly what those judges are looking for, and you've had that experience in the show ring. Bring that.
I think it does help. I mean, I do ride myself. I'm not saying I'm the best, but I certainly wouldn't be at Hoys quality, although I have completed in some Hoys qualifying classes before now. Not very successfully, admittedly, and my wife will point that out quite happily. But yeah, I mean, I've done that. I mean, many years ago I did a bit of dressage. I mean, when I first started off as a teenager, I was jumping and falling off a lot. But I've had a good broad range. But yeah, certainly more recently, as I'm getting older, the showing's a little bit more attractive, and certainly the lead rein, and now the first ridden with Zara, who's 7, is becoming a more commonplace thing.
Yeah, fabulous. So we've got you on the podcast today to talk about your experience of using stem cells. we thought it would be really useful for our listeners. So we have vets, nurses, other paraprofessionals, and some customers who listen to our podcast. And I thought that your experience of using stem cells over the years would be a really good way to kind of provide that story and the different cases that you would use them in, and your experience. So you've been using undifferentiated stem cells for quite a long time now. But where did your journey with stem cells begin?
Yeah, it began quite a long time ago, actually, with one of the pioneers, certainly in the UK, of stem cells, Professor Roger Smith at the Royal Veterinary College, and he used to provide a service where you would take bone marrow derived samples, shall we call them, and then it was quite a complex procedure, actually, involving scanning, going in through the sternum, quite worrying, I suppose, when you were that close to sort of, cardiac puncture, as one of the warnings about doing the procedure was. I think you'd have to be trying quite hard to do that, but it was certainly a little bit nerve-wracking the first few times, and that you would then send them off. They would then culture them and send them back, and that then became unavailable for various reasons. I'm not sure why, and then it was more recently that different forms of stem cells became available, the tenogenic primed and the chondrogenic induced as well, which I have been using for quite a while, and then these undifferentiated umbilical cord derived mesenchymal stem cells became available. So it was obviously something I'm interested in from an orthopaedic point of view, and it did seem like the way forward was more orthobiologicals rather than perhaps still quite a successful way of doing them in regards to things like steroids and hyaluronic acid, various options like that, which obviously steroids are still an option and a very good option, but I just felt that they were quite a blunt tool, and I wanted a bit more of a rapier rather than a sledgehammer, shall we say, to sort of turn off the inflammatory response in there, and hopefully as well improve the healing by stimulating the healing aspect of that. So that was where my sort of journey started, and why I tend to use them at the moment.
Oh yeah, fantastic. And so you talked there about these undifferentiated umbilical cord stem cells. How easy have you found them to use?
Yeah, very easy, actually. I suppose the only slight inconvenience is the wait from ordering them, where you would see a case, and because they are fresh and delivered in that form, you don't have them sort of on the shelf, or certainly we don't. I can't rely on seeing enough cases in the period of time. I think it's about 19 days they remain active. I might be wrong about that, but it's a relatively short window. So, but having said that, the ones that I first started off over 20 years ago, you would have to take samples, send them away. They would then send them back, and that would take many weeks. Actually a lot longer. And I've always been a big believer in trying to get these treated as soon as possible. In the acute cases, particularly, the sooner you treat them, and certainly in the case of soft tissue injuries, if you treat them whilst there is still a lesion there, and a relatively easy lesion to inject, then obviously you have a better chance of resolution.
Yeah, absolutely. So over the years, we've managed to reduce that waiting time from actually about 4 to 6 weeks down to a week.
Oh yeah, and yeah. I mean, I suppose I'm being a little bit picky that I've got to wait a week, but it's and it is just a case of the ordering process seems to be very good. We order them, we then get a date of delivery, and we sort of make our arrangements about the administration around that delivery date.
Yeah, and you said that they were fresh, so and that means they're refrigerated.
Sorry, yes, yeah, chilled,
okay.
yeah.
Chilled, okay. So there's no processing time now, and as you said, there was quite a risk to the horse with the bone marrow sampling.
Yeah, I mean that's the only one I've done. I mean, obviously you can get fat-derived stem cells, and there are other options as to the source of them. But it was just the way with the Jamshidi needle, and you had to scan to get the right position. And it wasn't as risky as it sounds. It was pointed out that the heart was probably about 3 centimeters away. So, but if you'd really have to be shoving in the Jamshidi needle quite a long way further than you should to do that. So yeah, the risk was pretty minimal, but you were underneath the horse putting a needle into a horse's sternum. So yeah, there were risks associated with it. And yes, this is very convenient. You ring up, it's ordered, and it's already in an available way. So yes, it's very convenient.
And so you've mentioned using it in a range of different cases. Are you choosing orthopaedic as well, so intra-articular use as well as soft tissue? What kind of cases do you select for these things?
Yeah, I think one of my big things with stem cells, I mean, cost is an issue. They're not the cheapest option. Obviously, steroids will be far, far cheaper. But without the advantages that I like from stem cells. So to get the best use of them, you want to think that you have a reasonable chance of success with them, and injecting them into a very advanced degenerative joint disease, OA model of lameness is probably not much point, because by that time you've already got the osteophytes and it's quite advanced. So I do find it difficult to inject into those cases. So I suppose, yes, any sort of early onset arthritis cases, and I make that distinction with degenerative joint disease. So arthritis meaning it's quite recent, or soft tissue. I've found a lot of success with soft tissue probably because I believe I see them a little bit more acutely in that, the owners recognise a soft tissue problem maybe a bit sooner than they do an arthritis problem. So yeah, I find that it's probably a lot of soft tissue things, and I suppose as well the concern that when you use other things like steroids in a soft tissue, it's not always the best thing. The other orthobiologicals I've used, platelet-rich plasma, I mean that has mixed results, but I think obviously the clinical studies that have been done have maybe not had a standardization of that, and I feel that makes it difficult then to sort of trust it as a treatment option. I have used it with success, but I also have used stem cells where I feel it's a little bit more reliable. I know in the case of the product that I use, it's 15 million stem cells per dose. I think that's a minimum, isn't it? Which means you know what you're getting, rather than a lack of reliability maybe with some of the other orthobiologicals. So yeah, I would use it quite a lot for the reliability and the fact that it's an acute injury.
Yeah, absolutely. Yeah, we've got a lot of data especially on PRP out in the field, from humans, from dogs, from horses. But you're right, that lack of standardization is one issue where we just can't compare, study to study. We've got variation from the horse itself, the variation in the way that it's processed, the variation in the pathology that we're going to use it for. So yeah, it's very difficult to compare. So having that standardized product gives us a little bit more necessarily control, but predictability, would you say?
Yeah, I would say so, and I think again, it's just trusting the research. At the end of the day, I'm a general practitioner, and I'm relying on the people doing the research, and certainly when you sort of get doubt cast over a certain treatment option, it makes you a bit more inclined to use one that and trust maybe.
Yeah, absolutely. So when we're thinking about these cases that you would choose, so they're more acute soft tissue or early onset arthritis cases, what diagnostics are you using to get to that point of decision making?
Yeah, it's a really important point that Meg, because I mean the diagnostics are vital. You know, there's obviously there's research suggesting that even injecting stem cells remotely and even regionally, I believe, can help injuries. But if you're injecting it in the wrong place, as I see it, it's maybe not going to be as effective. So I think the lamest investigation, the diagnostics, be that, obviously nerve blocks initially or joint blocks. We prefer to do to localize the limbs that way. Okay, so there are some issues and it may be, a sort of a tendon injury where it's pretty obvious where the problem is and you may not need to block those. And that's visible on ultrasonography. But yeah, ultrasonography, obviously radiography, even CT and MRI. Not that we have those here, but that they are modalities that I would use to sort of accurately locate a problem.
Yeah, fantastic. And in terms of say an acute soft tissue lesion, you mentioned that there was a bit of a time critical situation there with those. What's the time frame that you're looking at to get the ideal outcome?
Sorry, what do you mean? Do you mean the time from diagnosis to injection, or the time from when the injury first occurs?
Yes, I suppose from when the owner would first notify you about the.
Yeah, so I think certainly with obviously one of the issues with ultrasonography is you scan too soon and you don't always see the full extent of the lesion. So we would commonly leave anywhere from, well, a minimum 7 days and preferably more like 10 to 14 days, even as long as 3 weeks sometimes before we scan. I would probably say I would prefer to do it more in the 7 to 10 day gap, or probably the median of 10 days, because then you've got that opportunity then to inject into the lesion and not have the thought that maybe it was starting to close over or becoming a bit more difficult to inject, or are you going to cause more damage? I think the issue with joints is obviously radiography too soon. You may be not going to see any visible changes on radiography anyway. So it then becomes more down to your block and the reliability of that you've identified that a particular joint is painful and you are then going to inject into it. So that it would be, I would say, ideally you would see them within sort of 2 to 3 weeks, probably, as any sort of injury.
Yeah. Okay. Wonderful. So what kind of time of onset would you expect to see results from stem cells?
Yeah, this is an important thing. I think I try and manage clients' expectations, because ultimately all we're doing with any of these orthobiologicals is we're relying on the horse, in this case, that the horse's immune system or repair system to do the job. We're just nudging it in a certain direction. That's the way I feel it. And okay, yes, stem cells do have an anti-inflammatory action that's beneficial, and you may see a pretty sort of a quick response with them. But I don't really see that as a significant thing. Yes, it's nice, and I suppose people want to see results, especially if they've spent a reasonable amount of money on a treatment. But I more manage their expectations into saying, look, this is still relying on the horse's healing system, and yes, it might improve the quality of the healing and it might improve the speed of the healing, but that may still, certainly in the case of tendon injuries, take many months. So it's not something to say, oh, your horse is going to be sound and you are going to be right immediately. Having said that, I have seen some quite remarkable, I mean, that sounds maybe a bit extreme, but I've seen some quite surprising results, shall we say, of certainly echogenicity within sort of 6 weeks of injecting it, which I can honestly say I've not seen before. I'm not, it may just have been, as you said, there's a lot of variation in the horses. It may not have been the stem cells. I know we're talking stem cells, so I suppose that the hope, the expectation is that it was that did the healing. But yeah, I've had some that within 6 weeks, but I still don't see that as, an instant, right, yeah, you can get back to jumping, or you can, carry on competing. It's not something that I would push, and like I say, I try and manage the expectations to make sure that they are aware this is still a long-term process.
Yeah. So especially with those soft tissue injuries, encouraging owners to just think about the long-term kind of treatment and therapy and rehab for these conditions, so that we don't say, oh yes, within 4 weeks this will be healed in some respects.
Yeah.
Just to give them that long-term
that's
plan.
it. And I think, we've had, I've had some this year that have, one horse, it was probably 2 months before Hoys, maybe not even that, and had a check ligament injury, which, okay, they're not necessarily the more serious types of injuries, but they can cause quite a degree of lameness, and we did inject that quite soon before Horse of the Year show, and it did go on to compete in the workers. So and that was probably a little bit earlier than I would like, but then they had a clear aim, and it was, we know why people have horses, okay, yes, some of them have them for pleasure, and it may be that it doesn't matter if that horse doesn't come out for many months, but certainly a lot of people I deal with are competing and want a sort of or have a time frame that they've got to work within. And yeah, sometimes we maybe push probably myself out of my comfort zone of what I think is a safe, in inverted commas, period of time to start. And yeah, sometimes it maybe does. I do things a little bit earlier than I'd like, but I'd rather be on the safe side and give them longer and give it the normal rehab. And again, that's another important thing. The rehabilitation program I produce is quite exact. It's quite precise, and I do rely on things like physiotherapy as an additional thing. That really is a vital part. I'm a huge believer in physiotherapy as an adjunctive treatment to all these sorts of injuries, and just comparing it with the human side. If you have a surgery or you have a procedure done, often it's the physiotherapy that is the thing that brings you back at the end.
Yes, yeah, absolutely. So for kind of the vets listening, if you've got that conversation with the owner about what their expectations are, what they're going to fit in with their time frame and their goals for their horses, you got that choice, haven't you? Are we thinking kind of quick fix steroids, obviously maybe not for a soft tissue, or we're thinking longer term, how are we going to get this horse right for the long term?
I suppose I see steroids as a fantastic anti-inflammatory, and you're right. That there are, I use them a lot. I'm not saying I don't use them, and they're used as a very good anti-inflammatory in the short term, in the acute cases, and may even be used sometimes. I don't tend to use them prior to stem cells, but my concern is the long-term delay in healing. That certainly seems to be sort of concern with steroids. But yeah, there are some cases where you do just have to give them steroids and hope. But I would, as I say, I like the orthobiologicals because you are doing things the right way, in my opinion. It's newer technology. I feel it's the way we should be looking at these things, rather than the blunt tool, as I said, of a steroid, that I almost feel like you're not burying your head in the sand, but I feel it's not, you're not seeing a true picture after that point, and yeah, it may not be the best for the horse in the long term, in my opinion. I know there is a need for them. There's a use, and like I said, I do use them a lot. I'm not one of these people that doesn't use them. But there are certain situations where I would prefer to use an orthobiological, and stem cells are a good option for that.
Yeah, Yeah, so we've just got our spectrum of use, really, haven't we? And it's
Yes.
discussing with each owner what their individual goals are and expectations. And
Yeah.
how long do you think the duration of action has been? Say for maybe a arthritis case that you've used them in. What have you seen as a good kind of duration of action?
I think that's hard to tell really, because again, as I say, you're relying on the horse's body, repair system to do the repair. So, and that repair does tend to be ongoing. I suppose, you always have potential setbacks with these where the horse might, get loose from the owner or gallop off, too soon or something. There are always situations, or not always, but that's a common thing I find. And that may then set back, but it may not be that it's set back as far because the stem cells are there. They do carry on healing. I mean, in a way, I'd like to think that, as again, the support program I give with the rehab and the, not me personally physiotherapy, but, getting physiotherapists on board, is pushing the horse in the right direction. So is that the rehabilitation, or is that the stem cells? Honestly, I don't know. I'd like to think, given the mode of action and the way that it's pushing it down a certain pathway, the stimulation of repair cells, the interleukins that it encourages, and the initial anti-inflammatory against the inflammatory interleukins and MMPs. I feel that it's that is a good start, and the rest of it, you're almost setting the horse up then to repair. You're pushing it down that pathway. So that's the way I see it.
Yeah, yeah. And I suppose asking the questions of the speed of onset or the duration of action is really trying to compare an orthobiologic to a pharmaceutical. So they're almost the wrong questions to be asking about an orthobiologic.
I do think that there's it's very difficult sometimes to look at, are the stem cells working? Like you say, it's ultimately, is the horse sound? Is it competing? Is it responding well to the rehabilitation that you're asking of it?
Yeah, absolutely. So is there a case that you've seen recently, or one that really sticks out in your mind that you could talk us through? Kind of how is that worked up? What other considerations did you have for, and maybe it's diagnosis or it's treatment?
I suppose probably the highest profile one for me was one that, I won't mention names obviously, but it was a hunter that ended up winning Horse of the Year show, and that had a suspensory injury that blocked out very successfully. There were no signs on radiography. Ultrasonography showed a lesion in the proximal suspensory region, and it was a true lesion. It wasn't just a chronic lesion, and the horse actually was quite worryingly quite lame, probably about 4 out of 10 lame at the initial examination, and it was a concern, because I thought, this horse wasn't going to get better, and that did respond. That was probably in the March of that particular year, and obviously Horse of the Year shows in October, and he had to qualify that year as well. So we managed to get him qualifying within probably, I think it was about 4 months, which again would be a little bit faster than I would normally like with suspensory injuries. I'd normally like to give them 6 months, certainly from Sue Dyson's work many years ago, saying that was a reasonable period of time for healing. So 4 months was a little bit earlier, but again, it was the sort of the time pressure of competing and well, in this case, qualifying to even compete at Horse of the Year show. So that was probably the best case I'd had, and that did really well. So yeah, I mean, there are others that maybe haven't been quite as successful, but that was one that was a standout one for me. And again, with the degree of lameness, because I don't normally find them that lame with suspensory injuries, but it definitely blocked out. And like I said, there were no radiographical signs. The joint it wasn't positive to block either. So, I do think it was a pretty accurate diagnosis.
So we've talked about your experience of using the undifferentiated stem cells and how the horses respond to that. But what about the clients? How do they feel about using orthobiologics? They're relatively new. It might take a little while for them to understand the science of that. How have you found that they've responded?
Yeah, it's a good question. You've got to have a good detailed conversation with the clients, because well, stem cells are not always covered by insurance, and we have a lot of insured clients, or horses are insured, and that has been a problem on a few occasions. So we do have to talk them through that, and yeah, we've been caught out on a few of those where I remember one case where they did actually use it and then found out afterwards the insurance company wouldn't pay. So we're very aware of that now, but also then there's the conversation about these drugs are relatively new, and okay, yeah, like I said, I've been using similar products for quite a long time, but we have to have that discussion about, potentially, certainly in the case of soft tissue structures, it may be used on the Cascade, and the owner's got to be fully on board with it, because, as I mentioned earlier, it's not a cheap product, and it's not ridiculously expensive, but it's also, it's not on the level of steroids, where it's a very cheap product. But yeah, as long as you have that conversation with them, and I do find a lot of my clients are very, very proactive, and actually want to do which I know a lot of clients are, but want to do the best for their horse, and if that means using a product that is recommended by me, and thankfully a lot of my clients trust what I say, and like the fact that I am using the sort of, as I regard it, cutting edge technology.
Yeah, absolutely. I think that conversation is really important. And what about, I've been hearing quite a lot recently, is owners are increasingly concerned about laminitis, and the potential for steroids to induce laminitis in their horses. Are you experiencing that with your clients, and how do orthobiologics fit in with that conversation?
Yeah, and obviously a lot of show ponies in particular, and I make this distinction of ponies rather than horses, are maybe EMS cases, or potentially EMS cases. A lot of them are fat, that comes with the territory of show ponies, and yeah, it is a big problem, and I have had cases of steroid induced laminitis. I'm convinced, so I do worry. Okay, the dose of steroids that I use is regarded as a safe dose. I know that nothing can be completely safe, and I will commonly take bloods to check for their EMS status if I am really worried about an injection of steroids in a case. So I suppose we're aware of that, clients are aware of that, and it has meant that in some cases we haven't used that, and we've maybe used other treatments, not necessarily stem cells, maybe hyaluronic acid, maybe polyacrylamide gel. There are other options as well as stem cells. But yeah, I mean, if stem cells are an option, and finances will cover it, then yeah, we will commonly use that, especially in these little ponies, Section 8 ponies, as I've got myself. We are concerned that, maybe, I'm in touch wood, she's not going to be lame, but if we ever had to use something, it probably wouldn't be steroids.
Yeah, absolutely. It is a concern, a rising concern. But luckily we've got all these different options available to us now. So, well, it's been great talking to you about this, and I can hear your experience is really coming through, and I think that is such an asset for your clients. So I just want to summarize with the same question I ask all my podcast guests, which is, what three things would you tell other vets who are listening, and what would you tell them about using undifferentiated stem cells?
Well, you've known me for long enough, Meg. I can't just narrow it down to three things, and I've sort of yeah, I've been thinking hard about this, whether we can get it lower. But I think the most important thing is, well, I would say 10 most important things I would talk about. So one is case selection. It's an expensive treatment option. So I think you've got to make sure your case selection is correct. I think you've got to make sure that you, in my opinion, you've got to use it in more acute cases rather than chronic, otherwise you don't get the full benefit from it. So I think that, again, I find that the soft tissue ones that I've used it in have been better because I maybe get them more acutely. Good diagnostics are essential. I can't say too much about that. You injecting it in the wrong place. As I mentioned before, there have been reports about, I think it was like regional injection, maybe going to the right area. But I think, again, in my opinion, I feel if you inject it into that particular area where it's needed, it's going to have the best effect. So that's my requirement. As I said, client communication, managing client expectations, I think is a really, really important thing because we don't want to give the impression this is a wonder drug and it's going to make, the persistently lame horse completely sound forever. I think you've got to manage that, and sort of along with that as well is informing the client about the treatment, how it works, and and as we mentioned about Cascade, making sure that they're aware that it's not always available for soft tissues except on the Cascade. Insurance implications, we already talked about that. Not all insurance companies will pay for it. And then just making sure that when you inject the stem cells, again, you inject it in the right place. And I would certainly, in the case of soft tissue, I always use ultrasound guided. I know that probably sounds an obvious thing to say, but you have to make sure you're injecting it into the correct area. So I would use an ultrasound machine in most cases for that. And then the immediate post-injection management, should I say, is really important. Keeping the leg bandaged, stopping swelling. I've only had one reaction to stem cells over the years. I mean, it's probably, what is it, about 2.5% of my cases, and that came up with a local swelling immediately after. In fact, it was the one that was going to Horse of the Year show this year, which ironically, you'd like the one that you could do without. But anyway, it settled down in time and she did make it. But yeah, that immediate post-op management, and not that there was anything wrong with that, it's just making sure you bandage it, making sure you protect against infection, because obviously you can't inject anything along with this. I mean, in some of the joints I inject with steroids, I might inject, say, amikacin, gentamicin with them, but you can't do that with stem cells. So making sure that area is well bandaged and make sure your technique is completely aseptic is really vital. And then it's what I said about rehab, physiotherapy, all that sort of management, again, vital. And then monitoring it, monitor them regularly with follow-up ultrasound scans and things like that. So sorry, I can't narrow it down to 3, and I'm sorry for being so verbose, but I had to do those 10, I'm afraid, because I do think they are really, really important. It might sound like I'm wittering on, but I think it is so important, each of those things, almost with any drug, but I think particularly with a drug that is new like this and is relatively costly.
Yeah. No need to apologise. I think your experience is coming through, and it's really valuable to our listeners as well, who may be thinking about using stem cells but have not kind of made that first move. So thank you very much for joining me on the podcast.
You're welcome, Meg. I've enjoyed it, actually. It was a bit nerve-wracking to start off with, but no, I've really enjoyed talking to you.
It's been great. Well, thank you very much.
Thanks for tuning in to the Nupsala podcast. This is one of many insightful episodes that we have in store for you. You can stream the episodes on Spotify, Apple Podcasts and Amazon Music. Simply search the Nupsala podcast. You can also watch on YouTube or directly at nupsala-learning.co.uk. If you'd like to stay up to date with all our latest content, please follow us on social media, where we always post when a new episode launches. All the links and details are in the bio. Thank you.